Welcome to our video on immediate and early postoperative fever. Let's get started. So here's an overview slide of what we'll be discussing in this lecture. We'll start with the definition and the pathophysiology, and then move on to the different subtypes of postoperative fever. And in this video, we're focused on immediate and early. So let's start with the definition. Postoperative fever is defined as an elevated body temperature of greater than 100.4 degrees Fahrenheit, and that's after a surgical procedure. In most cases, postoperative fever self-resolves without treatment. However, it can be a consequence of a serious complication, so a workup to identify the underlying cause is very important. Now let's understand the pathophysiology. A stimulus, such as tissue trauma or even inflammation, endotoxins, and exotoxins from bacteria, activate the reticuloendothelial system, as well as endothelial cells and macrophages. And all of that combined increases cytokine release, and the ones that you're thinking of specifically are interleukin-1, interleukin-6, tumor necrosis factor alpha, or TNF-alpha, and interferon gamma. So IL-1, IL-8, TNF-alpha, interferon gamma. So those cytokines affect the preoptic nucleus of the hypothalamus, and that increases prostaglandin E2 release. So you activate the hypothalamus, you get this prostaglandin E2 release, and it's that prostaglandin E2 that increases the hypothalamic temperature. So that set point increases and the patient has a fever. So now let's move on to the different subtypes, starting with immediate postoperative fever. Usually the immediate postoperative fever starts within the first few hours following a surgical procedure. So when we think immediate, think first few hours. Now, the following conditions can induce immediate postoperative fever, and they're commonly tested on exams. So let's go through these one by one. Malignant hyperthermia is generally observed within less than 1 hour after induction of the anesthetic, particularly when you're using something like succinylcholine. And that results from profound calcium accumulation, and all that calcium results in intense muscle contractions and cellular hypermetabolism. Okay, so that's the first cause, malignant hyperthermia from succinylcholine. The next is febrile non-hemolytic transfusion reaction, and that occurs within 1 to 6 hours, and that's because of a blood transfusion, and it's a consequence of a passively transfused cytokines. So you're transfusing those cytokines, and then the patient has antibodies that react with those donor leukocyte antigens and cause a postoperative fever. Next is a pre-existing infection. And that's probably the most intuitive one that we don't think about, because you're thinking of a postoperative fever occurring as a result of the operation. But in this case, you want to think beyond that as well. Think, okay, they might have actually had an infection even before we started operating, but we just started to notice the fever a few hours after the procedure ended. And lastly, preoperative or intraoperative tissue trauma and the resulting inflammation can lead to immediate postoperative fever as well. Now let's move on to the discussion about the clinical features. So as mentioned on the previous slide, increased intracellular calcium accumulation in malignant hyperthermia that causes excessive muscle contractions, leading to muscle rigidity. And that increased intracellular calcium also induces hypermetabolism within the cells. So that results in fever. And the increased buildup of carbon dioxide and acid can lead to hypercapnia and acidosis. So that increased demand on skeletal muscle cells is not sustainable, obviously. And over time, those skeletal muscles begin to die. And when they die, they release potassium and myoglobin. And that leads to hyperkalemia and myoglobinuria, respectively. And hyperkalemia, as a brief review, can induce arrhythmias, while myoglobinuria can induce renal failure, because the myoglobin is toxic to the renal tubular cells. And febrile non-hemolytic transfusion reaction results in fevers, chills, myalgia, and nausea. And all of these clinical findings could be explained by the inflammation that ensues due to the presence of the antibodies in the patient's serum that's directed against the donor white blood cells, and then of course the accumulation of cytokines stored in that blood. Now let's cover diagnosis. The diagnosis of malignant hyperthermia is usually made clinically, and that's based on the classical clinical presentation and laboratory findings. So when you're thinking clinically diagnosing this, you think they had succinylcholine, they have a very high temperature, there's muscle contractions, and on laboratory testing, what would you likely see? High myoglobin and high potassium. Now, in equivocal cases, a caffeine halothane contracture test or even genetic testing can be done to confirm the diagnosis of malignant hyperthermia. Okay, now let's move on to the next one. In febrile non-hemolytic transfusion reaction, fever and chills typically begin within 1 to 6 hours after the transfusion ends, and that really is a diagnosis of exclusion. So you're trying to think about these other causes of postoperative fever. So you're thinking infections. You're of course going to think about malignant hyperthermia. And again, you'd really only suspect that if the patient was given succinylcholine. But then once you've ruled that out, then you can start thinking, okay, maybe it was a transfusion reaction. Now let's move on to the next one. Speaking of infections, pre-existing infections are common causes of immediate postoperative fever, like we discussed before. So how do you diagnose it? Well, the initial workup includes a CBC, urinalysis, and blood cultures. And that makes sense. A pretty broad array of labs. You're just trying to identify where the infection is coming from. And this is very similar to the transfusion reaction. You're trying to think, okay, what could be causing this? It's not clear. If it's not any of these other things, then maybe it's just an infection that they had underlying even before the procedure. So just get these basic labs. And if you suspect that it's a respiratory issue, then you can get a chest x-ray as well, because they could have pneumonia. Now let's discuss the treatment. So to treat malignant hyperthermia, you discontinue the offending agent first. So that's fairly intuitive. You want to make sure that succinylcholine is no longer in the system. You want to stop giving it to them. After you've done that, you want to start cooling. You want to give them dantrolene, and then you want to give them 100% high-flow oxygen. Now for the management of febrile non-hemolytic transfusion reaction, acetaminophen as a treatment and leukoreduction as a prevention are recommended along with the termination of transfusion. Again, it's logical you're going to want to stop the transfusion, but then you just want to remember you're going to bring down the temperature with acetaminophen. And then, of course, if you identify an infection that they've had, like a UTI or pneumonia, give antibiotics. Now here's an overview slide of postoperative fever subtypes again. So again, we just talked about the immediate. Now let's talk about the early postoperative fever. So early postoperative fever refers to a fever arising between postoperative days 0 to 3. And on postoperative days 1 and 2, then patients can have atelectasis or pneumonia. Now atelectasis, as a brief review, is just the collapse of the lung, resulting in reduced or absent gas exchange. And that can happen because the postoperative patients oftentimes spend the majority of their day sitting or lying down, and they're not fully expanding their lungs when they inhale. And so some alveoli start collapsing. In addition to just sitting or lying down a lot, these patients often have poor inspiratory effort just because they're sedated or because their pain is so bad that it's hard for them to actually cough fully or inhale fully, especially after intubation or anesthesia. So that was atelectasis. Now, postoperative pneumonia can be either hospital-acquired, occurring within 48 to 72 hours after admission, or ventilator-required, occurring 48 to 72 hours after endotracheal intubation. And note that most of the postoperative pneumonia cases are from gram-negative organisms like Pseudomonas, Klebsiella, and Enterobacter. So again, just to summarize, when we're dealing with early postoperative fever, you're thinking days 0 to 3, think atelectasis and pneumonia. Now let's continue with the clinical features. Both atelectasis and pneumonia can compromise the function of the lung tissue and result in tachypnea, dyspnea, cough, and hypoxemia. And that all makes sense. They're not getting enough gas exchange, hypoxemia, they're coughing, uncomfortable, they don't feel like they can breathe, and they're just breathing a lot. However, in atelectasis, the alveoli are collapsed and the airflow is limited, so you might not even hear much. So just recognize that in both types, atelectasis or pneumonia, clinically they're going to be very similar, like on vital signs and if you just look at them. But then if you listen to their lungs, in atelectasis, you can hear decreased breath sounds. Now pneumonia is just the opposite, and that's because fluid, which generally transmits sound better than air, is accumulating within the lung parenchyma. So you're actually going to have increased breath sounds. And knowing the increase or decrease in breath sounds can actually be a very important clue in a question stem, not to mention clinically. So you walk into the room, you've got this patient who's breathing a lot, you look at their monitors, their O2 sat's gone down, they're coughing, and they say, I'm short of breath. Then you think, okay, this could be atelectasis or pneumonia. Then you do a thorough pulmonary exam listening, and with your stethoscope, if you hear decreased breath sounds at that point, which of the two is more likely? More likely atelectasis. And then just the opposite with pneumonia. Now let's do a quick question to apply what you've learned. The intern is paged to the bedside of a 45-year-old female after she developed a low-grade fever and shortness of breath. She is on postoperative day 2 following an uncomplicated cholecystectomy. Lung examination is notable for diminished breath sounds at both lung bases. What is the most likely diagnosis? Okay, so this patient has a low-grade fever on post-op day 2. So that's making us think of what type of postoperative fever? The early type. And what are the two most common causes of early postoperative fever? That would be atelectasis and pneumonia. And clinically, she's short of breath. And on lung examination, there are decreased breath sounds. So which of the two is more likely? Pneumonia or atelectasis? Well, it would be atelectasis. So that being said, the intern in the question can certainly order a chest x-ray that can really help diagnose or differentiate between the two. So thankfully, you don't have to rely on your ability to listen to the lungs. It just gives you evidence to point you one way or the other. But you're still likely going to get a chest x-ray. And that brings us to diagnosis. So for the diagnosis of postoperative atelectasis or pneumonia, a chest x-ray is recommended, and that usually reveals collapsed areas of the lung if you're dealing with atelectasis, or consolidation if you're dealing with pneumonia. Next, a CBC is done to show if there are changes in blood cell counts, and then a sputum culture is actually recommended if they're coughing and it's productive. So a lot of times the cough won't be productive, but if it is, get a sputum culture of it. And blood cultures are indicated if the infection is so severe that you're suspecting sepsis, which is most of the time because they're going to meet SIRS criteria, usually with the tachypnea, tachycardia, and the fever. And then if you think, oh, this is likely a pneumonia, an infection, then you're going to get blood cultures because at that point you're thinking about sepsis because they qualify for sepsis. And then naturally, because you're dealing with a pulmonary issue and you're worried about sepsis, an arterial blood gas is recommended because it can help you evaluate the acid-base status and their oxygenation. So now let's look at an actual chest x-ray. So here you can see on the patient's right, there's a lower lobe atelectasis, and that results from lung collapse and deflation of alveoli. And that's actually a pretty subtle atelectasis. Here you see an x-ray image of right middle lobe pneumonia. So you can see the consolidation that represents exudate formed as a result of inflammation. So again, you've got a consolidation, so you're thinking pneumonia. Now let's talk about the treatment of atelectasis and pneumonia in the setting of early postoperative fever. Treatment of atelectasis consists of initiating deep inspirations. You can help the patient do this using an incentive spirometer. And what this does is exactly what it sounds like. It incentivizes the patient to take deep breaths. And by taking deep breaths, it opens up those alveoli. In fact, atelectasis is so common in patients after a surgery because of things like pain and the sedation, and they're just lying around a lot, that you just prophylactically give them an incentive spirometer because you want to prevent this. You want to keep their lungs open. You want to keep their alveoli from collapsing. And along with that same idea, you want to get the patient moving. So early mobilization, along with bronchodilators and chest physiotherapy are really helpful. So just to review, in all patients after a surgery, you're going to have them take deep inspirations, give them an incentive spirometer, and try to get them mobile really early. And then if they actually develop atelectasis in spite of that, you continue to enforce or encourage them to do those other things you recommended, like the incentive spirometer and getting walking around. But you'll also do chest physiotherapy and bronchodilators. Now for the treatment of pneumonia, then oxygen supplementation is super important, especially if their saturation is less than 94%. And then again, once you've seen that consolidation on a chest x-ray, you know it's pneumonia, so you're just going to give them empiric broad-spectrum antibiotics, such as piperacillin tazobactam, because you just want to cover whatever they've got, especially if they're in the hospital. Because again, this is a post-operative fever, so you're worried about a hospital-acquired pneumonia. So go broad with empiric antibiotics like pip-tazo. And there's more that you can think about with regard to antibiotic treatment here, but we're not going to go any deeper in this lecture. For more details on that, you can go see our lecture on infections of the upper and lower respiratory tract. Now, other important causes of early postoperative fever are UTIs and surgical site infections. And some of the most common organisms that can cause a UTI are E. coli and Enterococcus, whereas a surgical site infection during this period is usually due to group A strep and Clostridium perfringens. But really, you're thinking of group A strep. So how do these present? Well, patients with a UTI typically present with urinary urgency, suprapubic pain, and CVA tenderness. That is, if the infection has ascended to the upper urinary tract. So you're worried about pyelonephritis. Common clinical signs of a surgical site infection include the presence of pus, erythema, swelling, and tenderness. So thankfully, early postoperative fever caused by a surgical site infection is really intuitive. You can figure that out quickly. Look at the surgical site and get used to seeing what is a normal healing wound and what is abnormal, what is infected. Now let's talk about how you diagnose a UTI and surgical site infection in the case of early postoperative fever. So first, urinalysis is obtained to check for nitrites, which can indicate the presence of bacteria. And the urine is also checked for the presence of leukocyte esterase, and that's just a marker of leukocytes. And on that note, the presence of more than 5 to 10 leukocytes in the urine is known as pyuria, and that's highly suggestive of a complicated urinary tract infection. And most labs will do this, but if the urinalysis is suggestive of an infection, then a urine culture is obtained to detect the specific causative organism. So typically you send a urinalysis to the lab, and then it reflexes to a culture if there's anything concerning on that urinalysis. And then a CBC can demonstrate any systemic inflammatory changes, such as leukocytosis And blood cultures are done to check if bacteria have entered the bloodstream. And then also, you can do an ultrasound to visualize any anatomic abnormalities that may have caused the UTI during this period. But I want to pause before we talk about diagnosing a surgical site infection. But before we get to the treatment of UTI and surgical site infections, just know that the physical exam of a surgical site infection is so important, because that can tell you, oh, this is a problem. You can even examine for wounds or catheters or drain outputs, supposing that this patient had that placed during a surgery, and see if anything looks strange there. Is there any erythema or pus or anything like that? And then just think intuitively. You're going to try to get a culture of the wound. And then, of course, you're going to send a CBC, because when wouldn't you when you're thinking about an infection? And of course, you can do imaging if you're worried about an intra-abdominal abscess. So you can think like a CT scan, for example. And just to show you some cultures, here we see a urine culture revealing colonies of Enterococcus, and that's a gram-positive bacteria. And recall that in the hospital, most UTIs are from Enterococcus. And now you can see E. coli. This is a gram-negative organism, and it's a very common cause of UTI in the postoperative period as well. You can note that cloudy, mucus-like appearance of those colonies. And then here we see pyuria. So that's the presence of pus in the urine. And that's a patient with a urinary tract infection and sepsis. And again, on the urinalysis, pyuria is defined as the presence of 5 to 10 or more neutrophils in the urine. Okay, so now you've got this patient. You're fairly certain after the labs and after your physical exam and just thinking intuitively that they have a UTI. How do you treat it? Well, for these, you're going to give broad-spectrum antibiotics. And that's going to cover most of the common organisms that are implicated in UTIs. For example, trimethoprim, sulfamethoxazole, or Bactrim, or cephalexin, or ceftriaxone, and fosfomycin are most commonly used in this scenario. And again, those will cover most everything, including E. coli and Enterococcus. But again, that's just empiric stuff that you throw at them. And if the urinalysis is positive, which it would be, or else you wouldn't be treating them, then it would reflex to culture, and within a day or so, you'll get the culture results. And then you can narrow your antibiotics to the specific organism. You've looked at the patient, you've done a thorough physical exam, you don't think it's pneumonia, you don't think it's a UTI, but this surgical site looks awful, and now you're just going to treat. How do you treat this surgical site infection? Well, what you do is delayed closure and apply wound dressings. Typically, that's adequate for a surgical site infection. Now, if the surgical site infection is deep or severe, or it's rapidly worsening, then you're not only going to do some incision and drainage and wound dressings and delayed closure, you're going to debride that and give them antibiotic. And that's pretty interesting because for a superficial, not super scary surgical site infection, you actually don't give antibiotics. But if it's deep and severe, you do. Now let's wrap up with a board-style question. A 24-year-old G1P1 female develops a fever and chest pain 3 days after a complicated cesarean section in which she sustained significant blood loss. She describes her chest pain as sharp and worse when taking deep breaths. Blood pressure is 130/75. Temperature is 38.6 degrees Celsius, and pulse is 97 beats per minute. Lung exam is notable for rapid, shallow breaths, as well as crackles on auscultation and dullness to percussion at the right lung base. Abdominal exam reveals well-healing incisions without any draining or oozing, and there is no abdominal or suprapubic tenderness to palpation. Pelvic exam is notable for a moderate amount of vaginal discharge that is not malodorous. There is no lower extremity edema or tenderness. Laboratory workup is notable for hemoglobin of 9.7 and a leukocyte count of 16,000. Which of the following is the most likely diagnosis? A. Atelectasis, B. Pneumonia, C. Endometritis, D. Urinary tract infection, or E. Wound infection. Okay, so this occurred 3 days after a C-section, and the patient develops a fever and chest pain. And that chest pain appears to be pleuritic in nature, just meaning it's worse when they take a deep breath. Also, her high fever, 38.6 degrees Celsius, and her pleuritic chest pain, and the crackles on the right lung base, as well as significant leukocytosis, are strongly suggestive of pneumonia. And that makes sense, because after all, this is the early postoperative fever category, because we're thinking within the first few days, not necessarily the first few hours of the surgery. So B, pneumonia, is the best answer. Now option A is incorrect because atelectasis typically results in only a low-grade fever and does not cause this stark leukocytosis. And why would it? It's not an infection. Just those alveoli have collapsed and they're not oxygenating their blood as much as they should. Now, option C is incorrect because endometritis tends to present with lower abdominal pain and malodorous vaginal discharge. And the moderate amount of vaginal discharge described in the vignette is a normal finding, especially in this immediate postpartum period, and it's known as lochia. Now, option D is incorrect because the patient was not reporting any suggestive symptoms of UTIs. For example, there was no dysuria, and she didn't have any suprapubic tenderness on abdominal exam. And lastly, option E is incorrect because the abdominal exam revealed well-healing incisions without any draining or oozing. So, you're not thinking of a surgical site infection. So that makes E, wound infection, less likely. So again, the correct answer here is pneumonia. And that concludes our lecture on immediate and early postoperative fever.